Thank you, Mattias. And I guess most of our participants already recognize you by voice because they should have watched the introduction to health economics that was put online for their interest. But let me formally introduce you, Mattias. Mattias, I actually already mentioned your name in when talking about if they are interested in more health economic trainings that you provide this training. So they have this, and I have it included in my slides for today as well. So they have the access, or at least the link towards your training. So you are an economist, and you obtained your PhD in 2006 from the University of Ghent with a dissertation entitled Economic Evaluation of Medical Innovations. And since 2005, you have been working as a senior health economist at the Belgian Healthcare Knowledge Center, KCE, an independent federal agency providing advice to policymakers. You are the founder of META, Medical Evaluation and Technology Assessment, that conducts systematic reviews and HTAs for foreign non-profit organizations, and you provide professional trainings, as I mentioned, in HTA and economic evaluations. Having followed your training, actually myself, I can only recommend this to all of you if you want to know more about this health economic assessment. Mattias and we know each other already for several years, and I'm very grateful that you are here every year to present the most recent updates. And I'm very happy that this year it's, I would say, top of innovation here in our program. Mattias, please don't let us wait too long.
Thank you very much, Hilde, for the introduction. I'm also very happy because a lot has changed recently with the new HTA regulation, and that's what I'm going to reflect on. I apologize for my voice. Maybe people don't recognize my voice. I have a little bit of a cold, but okay. I will first start sharing my screen. I have to make sure that I can see you myself.
Maybe while you do so, I can say something that I forgot to mention to the participants this morning. We didn't really, because we touched upon decentralized clinical trials and that they are more being deployed in the US. If you want to know more, we last year had a speaker, Pamela Tieners, who's leading a company specialized in decentralized clinical trials. If you want to know more, don't hesitate to reach out and we can dig up the recordings of last year for your information.
Maybe just asking, can you see my full screen? Do you see notes, presenter notes? Because I can't see.
No, we don't see your notes.
Okay, but you can see the full screen. Yeah, okay, then that's fine. Okay, so my presentation is on like I mentioned, the new HTA regulation and the impact on both the pre and post marketing studies. And the post reflects, in fact, to what in the previous presentation was mentioned, to the managed entry agreements. Hilde and her colleagues already shared some information on the platform. So it's referring to our projects on the managed entry agreements a couple of years ago already. Also another project in which we looked to survival and costs in a lot of indications and for a lot of drugs in oncology. And then the last one here is on evidence gaps. But in fact, the most important is not on the platform, and that's the link, and I will present further details on that, to the guidance documents that are set up to support the introduction of the new health technology assessment regulation. For those who don't have a lot of time, all our reports are available for free on the website of KCE, but there are also some journal articles reflecting on those reports. So if you don't have a lot of time, I would recommend reading first maybe these short papers. For the content of my presentation, happy that we have 45 minutes. Often it's in a rush and you just can say the most important things, but there's not a lot of space for nuance. And I think that's really necessary here. I will not immediately start with the HTA regulation. I will start first, just to be sure, very brief, registration, reimbursement, and some differences between what is acceptable for EMA, for registration, but what we need then for health technology assessment. Make the link to the managed entry agreements. What is their promise and background, but what we see in real life. And so we think it has a lot of potential, but we think it should be used otherwise than it's used in the past. Then just from the KC report on innovative oncology, some observations, what we see and what is a little bit disappointing, that what we have seen in this report. Then I go to the HTA regulation, make the link to these guidance documents, very important guidance documents, very interesting, published last year, and still other guidance documents are published in the next weeks and months. And then make the link to, based on this HTA regulation, I'm convinced that the situation of research before marketing authorization, but also after, that can be improved. So that's where I will end. You will see I put on some slides the word extra. I'm not using slides with just a couple of words. I know it should be that way, but I don't like that, because if people want to use the slides afterwards, then it's difficult. What do you mean with this and that? So there's a lot of text, copies also, print screens of my documents with highlights. That's for you to be able to use the slides afterwards. So you will also receive them on the platform. If you want to use the slides next year, you still can see what is the source, what is the most important thing. So I will also provide this extra information, but maybe I go a little bit quicker over those slides where the word extra is mentioned. Now, this just to be sure, it's important to know the difference for a registration. So to have market entry, you have this here, the figure, the slides for the drugs with the EMA, who is looking at quality, safety, efficacy. For the devices, it's through the notified bodies who look at safety and performance. But let's say that's something different than for the reimbursement. The reimbursement here on the right side, you have what we call the fourth and the fifth hurdle, cost effectiveness, budget impact. But in fact, more important is the hurdle also on the efficacy, effectiveness. It's not the same as at the EMA, who is looking at benefit risk. And benefit risk does not mean that you need to compare. Relative risk is something that we do in health technology assessment. There we look at a comparison with the current standard of care. In a benefit risk analysis, that's not always the case. People think maybe that's the case, but that's not true. So you can have a single arm trial, not comparing. You can have placebo controlled, not comparing with current standard of care. And it's possible that that is sufficient for EMA for registration. And for devices, we even have more that problem, but that's not sufficient at the HTA level, where you want to compare with standard of care. What are the most, and this is an example of an extra, right? It's just to provide you this information from Tafuri, who examined what is the advice from the HTA institutes versus the advice from the EMA. And there are big differences. The colors are a little bit unlucky because green is disagreement in this figure, red is partial, and full agreement is blue. So the negative ones are the green and the red ones. And then you see the most differences are in the comparator. So it's on the placebo versus active controlled. There are the most differences. And the second one is on the endpoints. Endpoints, come back to that later, on the use of surrogates versus the use of final. And for example, quality of life, I will also show you some numbers on that. Quality of life, it's accepted by EMA, but it's not a requirement. And we see that in a lot of dossiers, the information on impacts on quality of life is missing. So that's important to be aware of these differences, which in fact results that for a lot of interventions entering the market, that they are registered, but that the evidence is not sufficient for the clinical part of a health technology assessment. And so that's the reason why already in 2010, the system of managed entry agreements of the confidential contracts, it's Article 81 at that moment and 81 bis, now it's 111, 12 and 13, that they mentioned we don't want to delay access. So to support rapid access, we are going to allow a kind of managed entry agreement, which means, and the first idea, if you look to the first texts describing this, was on evidence generation. We will resolve the uncertainty, the scientific uncertainty. What do we see? What I can already mention, why I put evidence generation in red. I'm not going to say all, but most of the managed entry agreements, and that's not only the experience of the HTA colleagues in Belgium, but also from our colleagues in other countries, are about price negotiations and are not about solving uncertainties on the clinical aspects. It's not that they are not gathering specific information, they are, but the necessary information on relative treatment, on the added value, that is most of the times not included in the managed entry agreement, and it might be included in text, you should, but it's not provided. That's what we see if you compare at the end of the managed entry agreement or the new managed entry agreement, because they can just take another one after the 3-4 years. But that's unfortunately the observation. Come back to that in a couple of slides. Just for those who wonder where these managed entry agreements fit in the evaluation process, probably you already saw this, so I do this rather quickly. After CHMP opinion, you can submit a reimbursement request in Belgium. Maybe I just use this. You can see this laser pen if I'm just here. So at the moment you can submit, and in the first 90 days, you also have an evaluation report at day 60, but that's the assessment period. And then the next one, day 120 and 150, you have an appraisal with a provisional and or final proposal. And then the last 30 days, that's for the minister. Here you have, at the moment of the proposal, there's a possibility to go to managed entry agreements. That's linked to specific articles in the Royal Decree. And this is where this managed entry agreement comes in. Okay. Now, the risks on the managed entry agreement. The first risk on what we see, again, not only in Belgium, but also other countries, that is that the submission files, they are submitted earlier with the context of providing early access. But the problem is then, it's a lot of immature data that is used, a lack of head-to-head trials, and the use of the surrogates like progression-free, and not always the final endpoints. And then people think, but we will solve this in a managed entry agreement. The problem is on the evidence generation that in the new submission files, there's not a lot of additional information about relative treatment effects. I still have to stress that. It's not on the numbers, it's not on adverse events, it's not on what is the treatment duration, but on relative treatment effect. What is the added value versus the standard of care or the recent standard of care in the past? The stakeholders in that project at KC, we involved stakeholders from industry, from universities, from the mutualities from Risivinami. Stakeholders, in this case then from Risivinami, involved in the managed agreements, mentioned we don't have the negotiation power as Belgium. We are too small. If we ask for further evidence, they will say that's a problem because it's only Belgium who is asking this. And well, the headquarters says we cannot set up a trial specifically for Belgium, costs too much, etc., etc. Another problem is if you would say you have to do this, otherwise we will withdraw the reimbursement. That would be a very strong argument. But what do we see? That is that there is almost no withdrawal of reimbursement if no data is provided. So the incentive to collect further data if there's no exit strategy is very low. If I would work for a company and there's no exit strategy, I would say, don't perform the research. If you perform it first, it will cost you money. And secondly, you run the risk that if the result is not positive, that they have a good reason to withdraw the reimbursement or to lower your price. So you don't have really a good incentive to perform that research once you have your reimbursement. Another problem is the number of managed entry agreements. There's a snowball effect. At this moment, it's already the last Morse report, 2024 published, data 2022. About 40% of the drugs are under managed entry agreements. That's already mentioned in our first report. You will have a snowball once an intervention is under a managed entry agreement. You have a new on the market and they compare with that previous one, which has a confidential price. they will say, oh, we also need a confidential price because we cannot make it explicit what is the price of the alternative. And so you have a snowball effect, making your system very untransparent. Okay. This is just the extra information where we compared the dossiers for the reimbursement requests submitted before the managed entry agreement, and then looking if there's a period of 3 years. That's the classical period. Then you have 1 year to resubmit, and then they can have a new look at that reimbursement request. And so it's the expert who then looks at the information in that reimbursement request. So these are not our words. These are the words of the experts at Risivinami looking at that new dossier after the first managed entry agreement. And in fact, in those dossiers, most of the times you see no new clinical studies, still no comparative studies. We still don't know the impact on quality of life. So that's in fact very disappointing and a contradiction with the initial mindset for setting up managed entry agreements. Does not mean that we are against managed entry agreements. In fact, I'm personally much in favor of if they are used with the correct mindset. There's a lot to say about this, but for time being, the most important one is this one I mentioned here in green. That's making very explicit what is the uncertainty. That's in the assessment file of the Risivinami. What is the uncertainty and which kind of research design do you need to solve this uncertainty, and put that in a managed entry agreement. You can make it a condition and then see also if this research is performed, yes or no. Also, the international collaboration. If you want to avoid that, they say it's only for Belgium, the international collaboration for asking further research and also for the price negotiations. And I come back to that later after I gave some information on the new HTA regulation. So the goal should be, and I come back to that on my last slide, it's not only the fast access, but it's in fact first also trying to look where there is actually an added value for the patients and providing access for those treatments. I don't have this on a slide, but maybe it's interesting to mention this, but I don't know if people are aware. If you go to phase 3 studies, for example, a lot of people say, hey, already in phase 2, a lot, it's not a lot of people, some say already after phase 2, I want fast access. I can see this is the best treatment you can ever have for these patients. No, then in phase 3, and you cannot predict which ones, but it's half of them that still fail, just on the added value or on the clinical part. It has nothing to do with cost at that moment. But before going to the phase 2, the registration, it's about half that fail. And in oncology, it's even a little bit higher. And that's a number published, for example, by Pharma Intelligence over a couple of years. And you see that year after year, it's about the 50% or a little bit more than 50% who is failing. That's important to know. If you provide access based on, I think it will be better, that you still have to check, is it actually better or not? And there are exemptions of huge treatment effects, but these are the exemptions. Most have relatively small benefits, and it's difficult based on the incorrect research design to extract which are the good ones and which are the ones which do not provide added value. Okay, now what do we want to avoid? I will keep this brief because I want to go to the next one on the HTA regulation and these guidance documents. This is just based on this dossier where we looked for the period 2004-2017 for more than 200,000 patients in Belgium with 14, 12, 13, 14 indications, cancer indications, to the evolution in survival. It's just observation, has nothing to do with randomization, and also to the impact of expenditures. How high are the expenditures, the evolution in expenditures, drug expenditures over these 12, 13, 14 cancer indications. I'll just show here the figures for one, just to have an idea what is in that report. Maybe it's difficult to read, but you can ignore this, just characteristics of these ovarian cancer patients. And you have 3 figures. I have to read it myself. Here you have the observed survival probability for 3 incidence periods. So the red, the blue, and the green line is 3 incidence periods with a time since diagnosis up to 10 years. Then here again for all the incidence years, so from 2004 to 2017, the 1, 2, 3, 4, and 5 year survival probability, and here it's the median survival time. You see, for example, here the blue and the green line and even the red line, but the blue and the green are exact on top of each other. So there's no improvement at all over these incidence periods in survival. If you look then to the expenditures, then the difference between the green and the blue was exactly the periods where a specific drug is used. And you see there's a huge increase in expenditures. This is without the confidential price discounts. You don't have it for an individual product. That's also mentioned in that project, the information on the confidential price discounts. But here you see an example of the problem of seeing huge increases of expenditures and no impact on survival. Then somebody can say, of course, you have to nuance. What about quality of life? For about 40 products, we looked to about 100 HTA reports in total, of course, of independent HTA institutes. And for example, I work myself on this specific drug. We have a separate HTA on that. There's no improvement also for quality of life. Even it's the opposite. In the beginning, there's a decrease in quality of life due to this, the severity of the treatment also, okay? But what hopefully makes you think about reimbursement decisions is that we see in these observational information, and we have the details in the report, that is in about half we see improvements. That's the good point. Most of the time, slight improvements. But that also means in the other half, we don't see improvements in that survival. And then we look to the individual dossiers for the quality of life. And for those indications, you almost always have large increases in the expenditures. And that makes you think about the cost effectiveness, the efficient use of these limited resources. Also making the link to the next HTA regulation, again, like what we saw in the managed entry agreements, also in this project, the use in those 100 HTA reports, immature data, lack of head-to-head, the use of the surrogates, which is a problem, and the quality of life. Again, not our conclusions, but the conclusions of the researchers performing that HTA report. And that's why I now make the link to the HTA regulation, because I hope for the future we will have better information pre-market and post-market. And I think the major step forwards in the last decades in health technology assessment is this new HTA regulation. So first, a little bit of the principles, timelines, and maybe you already heard of GCA and GSC. That stands for Joint Clinical Assessment and Joint Scientific Consultation. I will also tell you something about that. Okay. So first, for those who are not aware of this regulation, then I would say pay attention, because it's a regulation that is already into force. It's approved in 2022. And it's now, in fact, there's a progressive application, and it started a couple of weeks ago, to the 12th of January 2025. On the next slides, you have the details of these dates. But for the medicinal products, they start in January 2025 this year for cancer drugs and ATMPs. In another 3 years for orphan drugs, and in 2030 for the medicinal products, it will be the full scope. Those 3 years here, between 2022 and 2025, were needed so that all countries, all member states could prepare themselves, and also to set up guidance documents, both for the procedures and the methodology. And that's what I will also refer to a little bit later on. Okay, just for your information, this is the article. If you would go to the legislation, where you see it's about the medicinal products, also the new therapeutic indications of these medicinal products, devices class 2B and 3, IVDs class D, and here you see the dates, but I leave this for you as information for later on. The key principle, and that's very important, the key principle is that for the evidence submission, for a health technology assessment, the clinical part, in fact, is for different countries most of the times about the same. So if a health technology developer in the past, before this regulation, he had to go to all member states. We want to avoid this. That's duplication of effort. And so it's an evidence submission one time by the health technology developer in this European HTA procedure. And then the work done in the GCA, just this joint clinical assessment, you see in the regulation, they refer to joint clinical assessment report. That's a description of the scientific analysis. So it's a very neutral representation of the evidence on what? The relative effects and the certainty around the relative effect. And that's important. That's this distinction in the beginning where I mentioned you have benefit risk. That is not necessarily a relative effect. And relative refers to compared to, and compared to is then the standard of care, what you use in the member states. So relative effect and the degree of certainty. It's driven by the member states. That just means it's an assessor and a co-assessor of two member states who will perform this assessment based on the methodology in the guidance documents. And all the other member states need to validate. There's also an obligation that this work, as a result of the joint clinical assessment, will be used in the national reimbursement procedures. That's an obligation. And the member states, I mentioned, it's just a description of the evidence. That means it's not a conclusion or a recommendation, not at all. That's still the responsibility of the member states. For sure, you then also have the cost effectiveness you have to look at, and that's something that is a responsibility at the national level. Okay, so drawing conclusions on the added value and the decisions on the pricing and reimbursement, that for the member states. Now, if you look to this, you need to take it into account. That means it needs to be available pretty soon. And that's then an ambitious timeline, which I show here. I picked this graph from the pharma.be presentation because it's more clear than our previous timeline. What does it mean? In the regulation, it's mentioned. So here on top, you have the EMA timeline. The EMA timeline, after a CHMP opinion, the marketing authorization is granted day 67. The file is usually 210 days. There's also a briefer one of 150, but usually 210 days. Then the marketing authorization. And then you have 30 days at day 97. This joint clinical assessment report needs to be available. That means you cannot start after the EMA procedure. You have to start during the EMA procedure. And that starts with the scoping. I come back to that later in my slides, but maybe it's interesting, I already mentioned it here. What means the scoping? The scoping means that it's not just a file that is submitted with, this is the evidence that is available. It starts with asking to the member states, what is the relevant PICO, referring to the population, the intervention, comparator, and outcomes. I refer to the most distinction between EMA and HTA advice is on comparators and is on outcomes. Here it will start with what are the relevant PICOs for the member states. So we refer to this, it's demand driven. It's not data driven. What is available evidence? It first starts with what is the information, for which PICOs do you need the information? So that's the scoping. Based on the scoping, there is a dossier that can be developed by the health technology developer. Right? So that's the dossier development. And then you have the joint clinical assessment based on this, the dossier that is submitted by the health technology developer. If you have any further questions on that, I'll be happy to provide further details. Then also you have the GSC. GSC stands for Joint Scientific Consultation, and that's nothing more or less than what we had in the past, the early dialogues. But not only with the people performing the HTA, there's also a possibility, you also had this already in the past, of parallel advice together with EMA. And we already had some interesting conversation between HTA and the EMA. Here, so it's on the request of the health technology developer. It's also mentioned in the text that for medicinal products, directly comparative clinical studies, which are randomized, very important, hopefully blinded and include a control group, shall be advised whenever appropriate. I come back to that later on. It's also to avoid uncertainty where possible. If you can set up the studies with the correct research design, correct comparators, appropriate comparators and endpoints, and it's clear which are these comparator and endpoints, you can avoid uncertainty once these studies are delivered. So a condition also for this joint scientific consultation, there are also now procedures that are written and will be published soon. One of the conditions, of course, is that you have this scientific consultation before you set up your phase 3 studies. So the study protocol should be not final, and so that you can have the discussion and, of course, correct. Sounds logic, but it's an absolute condition that you do this conversation before you start with your phase 3 studies. One thing that is interesting to add, that is, if you look to the regulation, the advice in the past, what is the difference with the EMA and HTA advice in the past? That is that the feeling of people providing HTA advice is that often we had the feeling that the industry is then looking at the advice of EMA, looking at the advice of the HTA institutes, and then often deciding we just go first for the registration, and then we see later on with the managed entry agreements, we solve the problems later on. And in fact, that's the advice of the HTA institutes was ignored. What have they foreseen in the regulation? And I think that's very important, is that it's still advice. There's no legal binding elements in the advice. But in the Annex 1 for the drugs and the Annex 2 for the devices, you see the following. If you had a scientific consultation and you submit your dossier for the joint clinical assessment, you need to provide an explanation for any deviation from the recommendations made. That's already giving you a push to think very well, can I follow this advice? And if not, do I have a good reason? If you don't have a good reason, for example, to include quality of life, and the advice is you can measure it with this instrument and you don't do it, and then later on you have the uncertainty on the impact on quality of life, I hope the consequences will be different than somebody who has followed the advice and is providing good evidence. Then maybe, I see I have 15 minutes of time left. Then maybe another thing interesting is that for supporting this health technology assessment regulation is that you have a coordination group. You have this group on the GCA, the GSC, the Horizon Scanning. That is that methods group. For Belgium, myself and Frank Hulstart are involved in this method group. That does not mean that we write all these guidance. That means that we also look for the correct expertise. For example, if it's on statistical elements, we look for the good statisticians to help in validating these guidance documents. Okay. The disclaimer is that there's a full confidentiality. We only can share elements from the moment they are validated by all member states and are made public on the website of the Commission. So I will refer to some of these documents which are already public. And I would say keep an eye on this link of the European Commission, because more information will follow in the next months on different topics, like on the scientific consultation and how they will be selected, etc. But I will refer to three very important ones. They made a ranking, which are the most important ones that we have to present first before 12 January 2025. One of the most important ones was on direct and indirect comparisons, linked also to the validity of clinical studies, and one on outcomes. So I will say something about these three. You will see the three numbers on my slides. The first one, that was March 2024, is about direct and indirect comparisons. And the classical elements are included, like a preference for the randomization, but it does not mean that indirect comparisons are forbidden. In fact, it's explicitly mentioned. And there's a preference there for anchored indirect comparisons. I will keep the details on what means exchangeability, has to do with the underlying populations, whether you can compare them, yes or no. But the word anchored is very important. It's like for the situation where you say, hey, there's an evolution through time. You have the consultation. You say, I'm a company bringing product B to the market. I have to compare with A. At the same moment, there's another company comparing C with A. Let's say that the first company was quicker. B becomes the new standard. And then the other company compared C versus A. And then at the moment of the decision, then they say, yeah, but the current standard is, it's already B. The anchored then means if B was compared with A and C with A, indirectly, A is providing you an anchor for the comparison, and you can indirectly compare B with C. But for the strength of that comparison, the initial idea behind it is that you keep the strength of the randomization. It starts from two randomized studies, and the one combined arm, or the similar arm, is the one who makes the combination possible. The document also refers to the single arm trials and observational, and therefore I will refer to some print screens of that document. You will see there are huge requirements requested for this, and in fact it's mentioning that these requirements are so high, it's on the known and the unknown factors that might have an impact on treatment effect, and the corrections for that are often unverifiable and unattainable. I will just share with you. This is the first one. It's in fact the next one. This is referring to this RCT, is referring to this anchored, but it's here in the conclusion, the parts in red. And this is a misinterpretation by some of the people I already talked to. They mentioned, hey, this guidance document is saying that single arm, you can submit with a single arm. And then, of course, it's not saying it's forbidden. You can. But if you read the texts, then you will see it's mentioning that these methods have huge problems. They provide unreliable estimates of treatment effect. It's mentioning that the certainty of the results are controversial. It's very likely, more likely than other techniques, to suffer from bias, more likely to underestimate the true uncertainty. And here at the end, it may well be that this evidence is insufficient for estimation of the relative treatment effectiveness in the context of the joint clinical assessment. And I will provide you the example of this other guidance document on the validity of clinical studies. Again, it's no conclusions, it's no recommendations, it's just factual, no value judgments, just giving the scientific evidence. And this guidance document, in fact, I will skip for time this one, say something. I will first show you this one, but for example, on single arm trials, this is mentioning it does not allow relative effectiveness assessment. And in fact, this document also shows you which instruments do you need to use for the risk of bias assessment. Like for a comparative non-RCT, it's the Robbins I tool. Here it's mentioning uncontrolled trials per se are of very limited value for performing relative effectiveness assessment, and so you don't need to do a risk of bias assessment because it will be always very low. That's very important to be aware of this. So it's not forbidden, but the consequences for the reliability of the evidence are very present. By the way, the other things next to the internal validity, it's also, for example, looking at this PICO, what we call the PICO match or mismatch. Is it reflecting the correct population intervention comparator and outcome? Okay. Now, there's a lot on this slide. That's one of the articles I shared with you through the platform, or the colleagues of Hilde shared with you. It's written together with our colleagues from IQWiG, Beate Wieseler and colleagues. And in fact, there's what we see is that there's a lot of enthusiasm for the observational real-world data. First, I will say very explicit, we are in favor of real-world data if used for the correct purpose. We are not in favor for the use of real-world data if used for an estimate of the relative treatment effect. I will show you some evidence on the next two slides why it's problematic. And in fact, what we see, it hinders efforts needed for the feasibility of randomized trials, because our German colleagues, they looked at all the dossiers on orphan diseases. And they saw that, in fact, in about 60%, some companies provided RCTs and others did not in the same indication. So for the same population, giving the idea that often it's a choice to go for randomized or non-randomized studies. And what do we see? That is then that people try to do a lot of effort, maybe more effort needed than to do a randomization, trying to look for an external control group, and then still receiving the comment and the criticism that it's not a good control group, that there's a high risk of bias, etc., etc. So then also with the discussions with our EMA colleagues, people start to wonder what is the most or the best approach, striving for the randomization still, even if the population is small and doing the efforts there, versus trying to set up control groups where we always have problems with it. Here we say that the conduct of RCTs, that should be supported. So instead of shifting for clinical research to observational study design, which still has major problems, the alternatives of combining better efforts and more efficient use of RCTs, that's something that we are much in favor of. You will always have exceptions where it's not possible, but we see that there are a lot of indications where people say we can't, but that we see it is possible. Like on the 60% that other companies said we don't do the RCT, and others said we will provide the RCT. Okay, but maybe that's also something for the discussion because there's a lot of nuance needed here for sure. On the misinformation, very brief, you have this slide, and the next one, I will just say it because this was an old one. It's already more than 10 years that it was published. This is a more recent one. Some people try to look with the best available statistical methods if they can replicate, based on real-world data, the treatment effect that they saw in randomized trials. Knowing that randomized is often in a very selective population, so that's under the ideal circumstances. If you cannot show it under the ideal circumstances, it will be difficult that something works under usual circumstances. So you can expect maybe a kind of trend that you have better effectiveness in the RCT, but in fact, whatever statistical approach is used, you see that this is a cloud. On the one axis, you have the treatment effect based on the trial, and on the other hand, you have the one that they try to replicate based on real-world data from the US count registry data, which is one of the biggest observational databases available. And so the conclusion here was you have a different inference for the relative treatment effect in more than 50% of time. So that's the reason why on this slide and also on the previous slide, it's providing misinformation. And you cannot say which are the studies where you can replicate and where a real world would provide you reliable information. That's unfortunately not possible. And then on the third one that I wanted to provide you, the guidance document on the outcomes. In fact, it's on the surrogates, and it's mentioned you can use surrogates if you provide strong evidence. And of course, there's a preference to use the final endpoint if possible, like on the quality of life, survival in the long term. Sometimes you have to wait long for that. So there are reasons that people want to use the surrogates, and we don't say, again, you cannot, but if you want to use it, the guidance document says you have to provide evidence. And by the way, a strong association refers in the guidance document to a 0.85 correlation. I'll skip the definition on the surrogates. I hope you know it's about the effect that you see on a surrogate intermediate outcome, like progression-free survival. If you have a positive impact on that, then you hope also to have a positive impact on overall survival and on quality of life. I'll give you some evidence on that, but the guidance document is in fact both in the scoping. So for the PICO, asking for the final and asking only for the surrogates if they are validated. And also for the reporting, in the reporting, it will be made very explicit what is the evidence. So the level of the evidence, the strength of the associations, the limitations, and when will we have information on this surrogate if there's no evidence at that moment. So when will we have evidence on the final endpoints? I skip that for the moment because I think this slide is more important. That's on this evidence. We have much more evidence now than 10, 15 years ago. You have the full references in the report, but if you look to Ciani in 2014, it's overarching studies, so very big studies, not just looking at one study, but at a lot of studies, in this case in solid tumors, there was a low correlation with overall survival. For Prasad in oncology, a low correlation for most studies, and Giawali, more recent, for all surrogates that are allowed by FDA, none of them they find a good correlation. The same for quality of life. By the way, disappointing, 350 phase 3 trials in oncology, only about half is measuring quality of life. So first advice would be measure it directly. Half is not. Some of them are not publishing the results. And from those publishing, based on the 147 trials, they find a weak correlation. So again, the advice here would be include the quality of life measurement directly in your studies. Don't use a surrogate for it. Quality of life is something you measure from the beginning, from the moment that your treatment is starting. from the moment you have progression of disease, that you see what is the impact of that progression and the new treatment on your quality of life. Avoid that you use it or try to include it in your calculations later on for an economic evaluation on an indirect measurement with a surrogate. It's giving you very uncertain results. And then coming to my couple of last slides, coming to the end, what then would we like to have? And what is the impact then of this new HTA regulation? Well, I'm reflecting a little bit on this document, this project on the evidence gaps, but in fact, that's published in 2021 and the regulation is from after that. So this slide, I can now reflect on this slide from the report on the evidence gaps in combination with the HTA regulation. What we see is that a lot of products enter the market based on the phase 2b/3 studies, where we have problems because for the HTA and for the discussion on what is the relative added value, because of the lack of the head-to-head and the active comparators and the non-validated surrogates. With the joint scientific consultation and the guidance documents, we hope that the trials think about this PICO and also about the outcomes in the first place. And for example, if you include quality of life, that will not extend your study and not make your study much more expensive. That's just including the correct endpoints. Of course, based on the scientific consultation, if it's about an active comparator, and if it's about, for example, impact on survival, which is on the longer term, that can make your study much longer. That's true. But what we want to avoid is that you have this post-marketing phase where we don't have an idea on the real added value and that the managed entry agreement is not solving this problem. So we prefer to be well prepared before the phase 3, have the consultation, and to set up the correct phase 3 studies before the products enter the market. So that's having better evidence at market launch. And then secondly, and I'm almost at the end, you already saw this timeline. Like I mentioned, you have here this PICO of all member states. You will have here after 30 days also the result of these PICOs. So every report for every PICO by every member state, you will see the results. For some it will be empty, for some it will be with problems of evidence. But what will we have? A situation where we can see countries with the similar PICOs and then also see what are the remaining research questions, where we hope that this will increase the international collaboration for asking for further research. If it's not only Belgium, but at the moment of the reimbursement, we see, hey, the Dutch colleagues, the French colleagues have the same problems. Why not asking it together? That we cannot say, oh, it's only for Belgium. The same for the price negotiations. If there's good evidence, but the price is very high, you also see with which countries have the same problem and that there can be a common negotiation. By the way, Benelux-A is referred to. It's very interesting, but Benelux-A is on the initiative of the company. It's not possible at this moment from a legal point of view on the initiative of the policymaker. That's something that we also recommend to the policymaker, that they would change this, that there would be a legal possibility if you see based on the GCAs that companies or countries have the same PICO and have the same problem with high prices for specific products, that they can negotiate together instead of skipping the markets or just making the distinction between the different markets. That would increase the negotiation power. And so also for the managed entry agreements, through this international collaboration, we hope that that would improve the content of the managed entry agreements and really trying to solve the clinical uncertainties. So that's my last slide. We think the focus should not only be on early access only, but on a better balance between early access, but also seeing the real added value of the products by setting up the good studies. And that starts at the EMA HTA GCA level, so pre-market with these early dialogues. And that continues once you decide on reimbursement at the national and international level with the managed entry agreements. And in the end, the goal is to have better reimbursement decisions. And with better reimbursement decisions, one of the elements that you have to think about is then to make more efficient use of the limited resources that we have. Okay, I'm a little bit over my time, but I hope this was interesting for you as information. Thanking you for following this presentation. And if you have any questions, feel free. Thank you.
Thank you so much, Matthias. I didn't see any questions popping up in the chat. So maybe I will just ask for my own clarification because I too got a lot of new information, very interesting, and I need to still digest it a little. But you said that for KCI's, the Belgian HTA, you and Frank are responsible for this methodology, but there are so much or so many things that still need improvements. How can it be
Yeah.
implemented? Is it how do you do that?
Yeah, you mean for the methods group, eh? So at the
Yeah.
HTA level, the European, not the national. At the
Yeah.
HTA level, at the European level, you don't have to see this as only two people from Belgium and two people from the other countries. You have to see you need representatives in that methods group. And for Belgium, that's KCE. For the other three groups, it was decided at Cerisif Inami. But of course, for example, in the methods group, we are in contact with our other colleagues at KC. I'm a health economist. Frank is a physician. We have our statisticians. We have our people specialized in data analysis, etc. So we make contact with them. For the methodology, we start from what is already available. We already have collaborations. You have UNETA. UNETA stopped now. But UNETA stopped. Some people don't know this, but the website
No,
also
I didn't.
the link you have is now a link. We added this link to our website because the old UNETA website does not exist anymore. But we didn't want it to work of UNETA to be lost. What happened in these guidance groups, we started already from the guidance documents that were available under UNETA. But UNETA was not all member states. Now in this European legislation, all member states need to validate, all member states need to agree. So they started with a selection, which are the most important ones on the outcomes, on the direct and indirect comparisons, on how do you do the methodology on risk of bias, which instruments to use, etc. So they started to set up priorities, and those are the documents that are published already. But now we are still continuing with others. Like now, I think it's not public yet, but for example, on the joint scientific consultation, what are the eligibility criteria? And what are the selection criteria? Because they will say we have the possibility for 10 early dialogues. If they then have 12 applications, how will you select? Well, in that document, they will say these are the selection criteria we will look at. And that's why it's not final yet, because they are now busy with the next guidance and methods documents to set them up, and every time with a first round, second round, third rounds, and then validation by all member states. That's a little bit how it works if you have a European legislation.
Interesting. And again, I will indeed update my knowledge too here with Junetta. Maybe last question because now we're really over time. With respect to well, I can imagine that the public acceptance and really highly applauded the Benelux initiative, but it's on the basis of the company's initiative.
Yeah.
Why don't they do this more often than?
I think you can ask it to companies why
Well,
they
we have
don't
Novartis.
apply to the Benelux. I can imagine that they also see that it's not always a smooth way. But if I may be very honest, you have game theory. If I would work for a company and I have to negotiate in confidence with different countries separately versus with several countries together, I think I will have better outcomes if I do it separately and that the countries cannot communicate with each other. So from a game theory point of view, I have an interest for very difficult files, and Zolgensma was a very difficult one, by the way. But why don't they have more collaborations in Benelux IE? Why are not for more files the request asked through the Benelux IE? In the past, you could also say, yeah, but it starts at different moments in different countries. And if you submit in Belgium, the 180 days start. If you decide to submit later in another other country, they cannot wait for each other because in that country, you have to perform your 180 days procedure. So I think everything starts with providing the legal possibility to countries' policymakers themselves that they can say, we see in the GCA, these are the countries with exactly the same PICO or some small differences. So we need to look at the same evidence. We have about the same possibility to pay. You don't have to do it with very poor countries versus very rich countries. But if you do that for the Netherlands, France, Belgium, Ireland, etc., they can do the assessment together and then also see not only for the assessment of the added value, but also for the cost effectiveness and the price negotiations. I think it's very needed in the next years that somebody is making work of this to provide this legal possibility to start the Benelux AI or more with other countries together, the possibility for the negotiations to do it together.
Towards a European Health Union. Although we are very fragmented and
but it's logic
growing apart.
once you start on the price negotiations, on the cost effectiveness, every system has its own possibilities and its own cost. So it's logic then that you do the evaluation context specific, but it's not logic that at the negotiation table you go as a small country instead of seeing the bigger picture of all countries struggling with the same big problems. And you can solve this better together, let's say. That would be a good approach. And the possibilities are there, but it needs some improvements.
Thank you. We went 10 minutes over time. Mattias, will you be there for the presentation of Novartis or do you need to?
I think it's very interesting, so I will stay here in the background. So yeah, looking forward also to that presentation.
Thank you. So for the participants, don't hesitate. It was a lot of information. Don't hesitate to come with some questions if you have some. We know that not all of you have a scientific or a legal or an economic background, so that doesn't matter. We are there to to help you solve some of your doubts or questions. We will reconvene at 4. Thank you for your presentation, Mattias and Sana, and see you in 20 minutes.
Okay.
Thank you.
Bye.
Bye.
Bye.